Good morning, everybody. We're going to get started in just a minute as we make sure that everybody has an opportunity to join in and be a part of the session. So just bear with us for a moment while everybody comes online. Well, welcome everybody to day 2 of Game Changers in Health IT. Yesterday, we saw and heard from some amazing speakers on a broad array of topics. And I'd like to take a moment. Let's just give a big round of applause to all of our speakers from yesterday. And I'm just realizing the futility of leading a round of applause when you're all on mute. So still, they were excellent sessions. So thank you to all of our speakers yesterday. And today promises to be just as exciting. This morning, we're going to hear from a panel on the promise of our HIEs and interoperability during this crazy time of COVID. This afternoon at 12, we're going to learn from Russ Branzell how Health IT will lead the way in battling COVID going forward. And at 4 p.m. today, we'll look even further into the future with a panel of experts about technology disruptors. Now, if your system requires it, or your organization requires it, we've also included a passcode for each of the Zoom webinars in this morning's email that went out. So if you're having trouble getting onto some of these sessions because you need a passcode, head into that email, check out the passcode, make sure that you have that available to you. So it's going to be an excellent day. So please do join each of the sessions and be sure to stick around to the end of each session, as we have a $200 gift card giveaway at each session. But like everything, you've got to be present to win, so stick around to the end. Of course, all of this would be impossible without the support of our many sponsors. So if you check out the chat window right now, we've posted a link to our virtual sponsor hall. So I just want to take just a moment, maybe 20 seconds. If everybody could just go click on that link from the chat window, have that web page open on your second monitor. Hopefully you've got a second monitor since we're all working virtually. Keep that up, and at the end of the session, we're going to invite you to head over to that page and check out those exhibit hall and those booths. Because in addition to great content and solutions, some of our sponsors are also offering amazing giveaways. So just click on that button to join their virtual session. Well, it's time to get this virtual show on the road, so to speak. And speaking of sponsors, it is my pleasure to introduce Gary Brayton from JCO Inc., who's here to introduce all of our speakers. So thank you, everybody, and enjoy day 2 of Game Changers in Health IT.
Yeah, thank you, Elliot, and welcome to the virtual demo. So Gary Brayton, JCO Inc., up here in Franklin, Massachusetts, and I'm just going to give you a quick overview of what JCO does. And while I've got your attention, I'll show you that we're a 48-year-old contract manufacturer here in Franklin, Massachusetts. This is our quick view of a 100,000 square foot facility here in Franklin, where we do all the design, fabrication, final assembly, and system test for our mobile cart line. We introduced a cart line back in 1996 with our partner Hewlett-Packard for early patient monitoring systems down in the Boston area, and has since expanded over the last 24 years nationally. So if our cameraman will just scan the room, we're doing about 5 virtual demos a day for our customers, as they don't really want sales guys on site. And it's been very efficient for our customers, because in 20 minutes, I can show them about a dozen carts and all of the features and options for EMR point of care carts, whether it's powered laptop or LCD and PC and laptop carts, or non-powered laptop and tablet carts to meet the COVID spike needs. The difference between Jayco and the rest of the point of care carts out there is we're all aircraft grade aluminum, baked on powder coat, antimicrobial, come with a 10-year warranty. We're designed to last 10 to 15 years, be very light, very user friendly, whether it's for the clinical team and it's a 73-pound fully powered cart that's going to run your PC for a full shift. It's only 73 pounds, which is anywhere between 20 and 40 pounds lighter than a traditional cart. Very easy to move, very easy with 2 fingers to go up and down. So again, fully powered, whether it's hot swap or plug-in, we have the ability to do both. We can outfit a cart with cameras and drawers if needed for telepresence or rounding and med surgery. And then again, not everybody in the EMR, with Epic and Cerner and the others needs a 24-inch monitor on a powered cart. They can get away with a laptop that's running on its own battery. And again, we can configure that so it's got a work surface, a full keyboard, a side access drawer, so you can do everything from the front of the cart. And not have to, move around the cart to get at the drawers, all the way to essentially our version of an IV pole or our iPad on a stick. But the difference again is aircraft grade aluminum. It's designed for acute care environments, 24, 365, abuse that these carts get. And with a 7-year warranty on the littler cart, the 10-year warranty on the full-size carts, they're designed to last 10 to 15 years. And a refresh will not have to happen every 4 or 5 years like it does with the plastic carts. Our customers are seeing anywhere between 10 and 15 years of life. They're seeing 4 to 8 years out of our lithium iron phosphate power systems. So no maintenance, 10-year warranty, metal versus plastic, made right here in America, and, oh, by the way, a certified woman-owned business in Franklin, Massachusetts. We're doing virtual tours all the time. We'd be more than happy to help anybody that wants to take 20 minutes and learn a little bit more about how we can help with the mobility of your EMR devices. So I think I have something else to say now. At this point, I'm going to introduce the speakers. So there's Jennifer D'Angelo, Senior Vice President for New Jersey Innovation Institute. Tom Moore, Senior Vice President of Innovation, Helix. Dr. Laura McCrary, President and CEO of Kansas Health Information Networks, Inc. Christine McBride, Program Manager of Health Information Exchange, Camden Coalition. And I guess at this point, I turn it over to Jim Hennessy.
Hey, Gary, good morning. Thank you.
Thank you.
One of the wonders, I guess, of one of these virtual tours and virtual things is being able to bring all that equipment onto the stage as part of the introduction. So one of the wonders and benefits of the virtual conference. So good morning, everyone. Thank you for joining us. We've got a great session this morning here that actually builds off of some of the sessions that we held earlier in the pandemic, as far as just trying to reach out to the groups and understand how our region's being impacted and all of that. So Dr. Ken Niganti and I are from the board are really excited to help drive today's discussion. As Gary had mentioned, 4 great speakers today, each to talk a bit about their HIEs and what this has meant to them and how they see HIEs helping us further in this public health crisis and how important those become. So I'm going to get it kicked off right away by introducing and turning over to Christine McBride, who's, as I mentioned here, is the manager of the Camden Coalition's Health Information Exchange. So Christine, I'll turn it over to you and get us kicked off here.
Great, thank you so much, Jim. Good morning, everyone. My name is Christine McBride. As mentioned, I'm the manager of the Camden Coalition's Health Information Exchange. The Camden Coalition is a regional nonprofit in Camden, New Jersey, where we work with medically and socially complex patients. And as you know, in my role, I manage the HIE. So just a little bit of background on the Health Information Exchange. Our regional HIE has been around since 2010, and it's a place to store clinical information for patients who have encounters at participating organizations. It is a tool that we're using to help our provider community make clinical decisions and have workflow support for different population health departments and primary care practices. Like I mentioned, it did launch in 2010, and it moved to its current platform in 2012, which is Care Evolution. And we use that platform along with other regional HIEs across the state in Trenton and Newark as well. So just for some of the features of our HIE that I think are really important as I talk through some of our opportunities and way the HIE has been used in 2020. Our HIE has a longitudinal patient record, so having around 10 years worth of data has been really helpful for some of our providers, to have a sense of some of the medical histories of patients, and also, with that medical history, really understand the patient's encounter history. So we do real-time encounter notifications to providers that can be directly through our HIE into their EMR or into some sort of data extract, which is really popular with some of the larger payer programs and pop health teams. We also do direct integration with EMRs for bidirectional exchange. And so, we're working through that with a number of partners now to make sure that, we're really thinking about, how the providers want to access data and what's the best way for their teams to have be able to see what data we have available in our HIE. Really this year, I'll talk about this soon in another slide, we've been really focusing on our custom form building and how we have a thin EMR functionality to allow providers to do some minimal documentation. And that, has been really helpful, I think, at a time of, changing health landscape with COVID. And so I'll talk about that soon. And then we also have some direct messaging that we'll use with providers, especially for some of our social providers who, are using the HIE in a way that may not be part of traditional medical information. And finally, our population level reports for data analysis has been, really, really helpful. So, we're doing that with, our partners to make sure that they're gathering the information that they need, whether that's from claims data or from our clinical system. So you can go to the next slide. Thank you. So for COVID-19, we really have been, making sure that our HIE can be the regional tool that our health systems would need for implementing strategies for vulnerable populations. For those of you who know about the Camden Coalition, we really do work with a lot of medically and socially complex patients. We're really, kind of trying to think about, who are those patients who may not get the services that they need. And during COVID, it was especially important to think about those patient populations. So we were making sure that we were expanding connections so that our HIE could receive more lab results, especially from local testing sites and from, as those would pop up at pharmacies and places like that. We were also offering regional support to our primary care practices in the county health department. One thing that we're really proud of that we did was, our county health department, alongside some of the homeless shelters, wanted to set up what they were referring to as a quarantine hotel, so a place where patients could go if they had reported that they were either experiencing homelessness or really just had no safe place to quarantine during the 7 to even 14 days that they were awaiting test results or really trying to wait out their COVID diagnosis. And while they worked with local homeless shelters to set up a referral process and a place for patients to go, they didn't really have the technology to do, to share information easily. So what we did was we had a form in the HIE that we could use to refer patients to the quarantine hotel. We built that out with them, and I think it was really important for sharing not just the COVID information that they were collecting for patients, but other important information about whether the patient had specific medications that they need to continue receiving, certain services, things like that. You can go to the next slide. Thank you. Another area that we've been focusing on is engaging skilled nursing facilities. So before COVID, we were really working with local health systems and their networks to build a way for SNFs to onboard to our HIE, knowing that they, may not have some of the resources to connect to health IT. So we started working with Genesis Healthcare. They have 12 sites across South Jersey that connected to our HIE back in March 2020. So we were right in the middle of that data integration as COVID was really, coming into New Jersey. And so, we were excited to get that across the finish line despite everything that was going on. And we are receiving from them ADT feeds, patient demographics, and continuity of care documents. So we know, what happened with the patient while they were at the SNF. And we are also working directly with point-click care. So we wanted to do a direct AMR integration, so that way skilled nursing facilities that are using point-click care's cloud-based platform could easily connect to our HIE with minimal technical work on their side. And instead, we're sort of focusing all those efforts within, between point-click care and our HIE. So we're testing bringing on 2 skilled nursing facilities data right now, and we're hoping to close that out by the end of the year. So then we can continue onboarding more SNFs. And staff at both sites are trained to access HIE data. So for both, the Genesis work directly and the other point-click care work, it's been really exciting to, show how the HIE can be beneficial to them. You can go to the next slide. So just to close out my piece of the presentation, I just wanted to give that quick overview. We're really focusing our HIE as a platform for data exchange and also as a place to co-design workflows with our medical and social providers. We try to think about it from this long-term view of not just how we're going to share data with others, but really what's the most impactful way that we can exchange information and collect data on patients and then analyze that. So we have a few other opportunities we're hoping to focus on through the end of 2020 and into 2021. Shoulder to shoulder support for SNF staff. So, we are hoping to be able to integrate the HIE more into their clinical operations. And so we're hoping to bring on more SNFs. We have behavioral health data exchange and increased support for our MAT providers, and apologies about my pet. So we're hoping to, bring on more partners in that space as well. We are also hoping that with social determinants of health data, we can bring on more social service providers and use HIE in that sense. And then finally, continuing support of the Camden County Health Department and other local county health departments that are, within our South Jersey area, and how we can continue building out technology that they can use for documentation purposes. So yeah, I know that was a quick overview, and I'm happy to answer questions at the end. And thank you again for allowing us to participate today.
Excellent. Thanks, Christine, to yourself and to your co-presenter over there in the background with you. And as Christine mentioned there, and I was going to do time, we're going to give each of our speakers a chance to kind of give a quick update like Christine just did about their HIEs and the work that they're doing. And then we'll kick into the Q&A. So over the time here, while we're doing that, if you do have questions, submit them through the Q&A. We'll go through those in addition to questions. Hopefully Kennedy and I will help kick off with the group. So with that in mind, let me turn it over to Laura McCrary, who Gary had introduced along with the others earlier, who's joining us from middle of the country out there in Kansas, where hopefully it's getting light out there as part of the Kansas Health Information Network. So Laura, why don't I turn it over to you and continue along.
Okay, thanks, Jim. I appreciate it. And hello from Kansas. It's very nice to be able to join you today. I was just thinking that this time last year, I actually joined you in person. Boy, what a difference a year makes, doesn't it? So I'm happy to really spend a little bit of time talking to you about One Health New Jersey. And I want to just make sure that you understand that I am the executive director of the Kansas Health Information Network, which is our statewide health information exchange here in Kansas. But in 2014, we were asked by a number of medical societies across the nation to expand into other states beyond Kansas. So currently we run One Health New Jersey in conjunction with the Medical Society of New Jersey. We also have a similar arrangement in Connecticut and in 8 other states where we provide our platform and our services. And the best way to really think about what KHIMSS does is that we're really a franchise health information exchange. that really you can just pick up and implement in an individual state or region. So for New Jersey, we've been in New Jersey now since 2017. And as you know, building health information exchange takes time and trust and a commitment. And so I've put on here the connections that we have. We are preparing to be a QHIN, which of course is going to require nationwide connectivity. And so at this time, we're connecting as many organizations together as we possibly can. It's all one platform, one technology platform. So if you're in New Jersey and you receive care in New Jersey and you go to Louisiana, where we also run an exchange, your information will be available on the same health information exchange platform in Louisiana. So we are a 501c3 not-for-profit. We are provider-led. Hospitals and physicians make decisions about the work that we do. We do have a network that is nationwide, and we have providers that are in California all the way over to Georgia and South Carolina and New Jersey and Connecticut. And we do extensively leverage eHealth Exchange to put connections in place. And a big focus that we have is to really look at the physician practices, particularly those that are independent that might not normally be a part of a health information exchange, either because they don't have a really sophisticated electronic medical record system or they don't have a dedicated IT staff. So we really focus a lot of our attention on independent physician practices. And we do that in New Jersey and all the states that we work in. Similar to the information that Christine shared with you, we have all of the standard health information exchange products and services. So a health information exchange, not only a portal view, but also we can embed in the electronic health record system to allow the health information exchange to come right into your Cerner or Epic or Allscripts electronic medical record system, and then actually be incorporated into the patient's chart. We also aggregate all of that data into an enterprise data warehouse and a data lake to allow us to be able to produce analytic dashboards for doctors and hospitals and others that aggregate the data from the health information exchange. So most of you know, health information exchange is really good at looking at one patient at a time, but if you need to look at all of the patients in your practice or all of the patients in your value-based payment model or in your hospital, you to be able to aggregate those into dashboards. Provide alerting. We're prepared also to meet the requirements for our hospitals as they have to provide alerting starting in on May 1st of 2021 to meet their conditions of participation. We provide data extracts, so that folks can incorporate data into their own population health tool, or they can incorporate data for a payer. We do, of course, provide direct messaging. We have a personal health record that's available for every patient in all of our states at no additional cost. We do support doctors in their MIPS reporting. We have a registry that they can use. And we do, of course, connect to eHealth Exchange and Care Equality. So one of the big important things that I think I would like to just point out kind of at the bottom of our connections there is that we are connected to NJDV. We're connected to HealthShare, which is also running an exchange in New Jersey. Our HealthIX connection with Tom is in progress in New York. So we believe that we bring a significant opportunity to access a lot of data when you participate in One Health New Jersey. Next slide, please. So what I really wanted to talk about today is COVID, and here in Kansas, we are seeing a significant outbreak. You guys probably are watching the map. Kansas is turning into burning red along with Missouri, and we are seeing, even on our team, we've got staff out with COVID, so it's affecting us pretty significantly. So we take this very seriously, and we looked out this summer, really in the spring and in the summer, about what was happening with our doctors in our hospitals. And we identified really 4 significant issues that we felt like we needed to address as a health information exchange. One really is something that I think that we sort of have taken for granted a bit, But, you know, a lot of times people will say healthcare is local, but with COVID now, what we find is healthcare is not local because we don't have the local resources to be able to care for all of the COVID patients. So patients are being transported to lots of different locations. We're seeing that now here in Kansas, where patients are not being able to get care at their local community hospital, either because the hospital doesn't have enough beds, they don't have enough resources, so they're being transported. And where they're transported, people don't know very much about them. So you have to use the basic functionality of health information exchange just to be able to share the medical information for patients as they're transported outside of their local communities. And then when they return home, those local communities need to know what happened when the patients were at the hospital. So basic health information exchange has become increasingly important as we see the patients moving around much more than perhaps, you know, what we would have normally considered to be normal referral patterns. The other thing that we found, and I'm sure that you found it as well there in New Jersey, is that the requirements for the reporting on COVID testing has become almost impossible for many of our providers to meet. Many of our healthcare providers do not have electronic lab reporting in place. Hospitals do, but an independent physician practice and their EMR system, they're never going to be able to have an electronic lab reporting interface because the EMRs don't build those. So we've got a lot of independent physician practices that are trying to manually report COVID tests. And I just talked to a group there in New Jersey who's doing 10,000 COVID tests a week, and they're trying to manually report those on an Excel spreadsheet. Well, that is completely unsustainable. So we have worked really, really hard to develop a way to use the existing ADT and lab feeds coming out of the health information exchange to be able to create a compliant ELR message. And so we'll talk about that a little bit more in our STARS grant. The other thing that we found is that our alerting product, which normally had been alerting just on ED inpatient admits and discharges, we realized that patients that had COVID, it was important for the doctors in the hospitals to be alerted that their patient had been diagnosed with COVID. So now as our part of our alerting product, we also have a tab for a primary care doctor or for another organization to click and see who are their patients who have been diagnosed with COVID, and to know right away because it's an alerting product. Then the last thing we realized is that our states didn't have the information that they needed to do contact tracing. That information doesn't come across in a traditional ELR message. So information about what county does the patient live in, what's their race, what's their ethnicity, what's their phone number, how do you get in touch with them? So we took all the data that we had in conjunction in the health information exchanges and created a comprehensive COVID registry for our states. So those are the things I'm going to talk to you about a bit. So let's go to the next slide. So we took all of those ideas that we had and we applied for the STAR HIE grant. Some of you might be aware of it. It's one of ONC's grant programs that they had available really at the end of August. And it really was designed to showcase the way that health information exchanges can step up and provide the products and services that no real other organization can do to help combat COVID. And so we were one of 5 organizations across the nation that were awarded the STAR HIE grant. And of course, we included New Jersey in our application. Next slide, please. So this is what we agreed to do as a part of our STAR HIE grant. It's a 2-year grant. And so we'll establish public health registries in all of the different markets that Kansa does business in. And so what we'll do is spend quite a bit of time right at the beginning here working with Rush University in Chicago, where they've had a lot of experience in really identifying the key components of COVID registries. And some of the things that we're not even thinking about yet, Rush is already thinking about and is going to help us build into the COVID registry. For example, patients who have had COVID and then, actually have COVID again. Unfortunately, we're starting to see that happen. Patients who have had the vaccination for COVID and patients who have not. Patients who have have flu in conjunction with COVID. Patients who have significant underlying chronic disease conditions. All of these things are important when you start thinking about how we're going to actually manage COVID or another pandemic that comes our way. And so again, as I mentioned earlier, we believe that you can use the existing HIE data feeds to create compliant ELR messages. And so we're building out that capability, and that'll allow independent physician practices or small hospitals. We have 83 critical access hospitals here in Kansas, of which an awful lot of them do not have an electronic lab reporting capability. And again, they're trying to report these lab tests, both positive and negative, by hand on Excel spreadsheets. And then we're going to really focus on practices, independent physician practices that have large numbers of COVID patients, to make sure that they're participating in health information exchange, and to make sure that they're able to effectively transport the positive and negative COVID lab tests, and make sure that they are able to share data with others who are providing care to those COVID patients. Next slide, please. These are the analytics that we built out that help to support COVID. And this is what's provided to physician practices and others that actually want to be able to utilize the data that's in the health information exchange. And so I'm not going to go through all of these, but key things to focus on is in disease registries, we have a drop-down list of all of a practice's COVID patients. And that helps the practice be able to see them, where those patients actually have come from. There's a nice map that shows them where their patients are located that have COVID. It also helps them from the perspective of looking at high-risk patients to be able to determine what are the other chronic disease conditions that their COVID patients have. It also helps them look at readmissions in terms of the number of times their COVID patients are being readmitted. So there's a lot of information here that we use with our analytics to really help manage COVID patients for a practice. Next slide, please. So this is just a quick example of what the registry looks like that we've built out. Now this is for Kansas here, but this will be what we look at for New Jersey. We'll be working closely with NJDV as we do this. But what you see here is basically across the top, you can see the sending facility, and then you can see the patient's phone number and address, what city the patient's from, zip code, what county. Again, this is some of the information that doesn't come across in an ELR message, what the diagnosis code is, which COVID diagnosis code is. You can see right now in Kansas at the top there, we're running 34,000 on the COVID patients on the day that I took this snapshot. Let's go to the next slide. So this is what the state uses then in terms of contact tracing. So you can see you've got patient's first name, last name, date of birth, gender and ethnicity and race, all of that's information that the health information exchanges gather. And so it's important to recognize that health information exchanges are probably the best source of data for actually managing COVID here. You can also see the date of admit. Unfortunately, on this particular slide, you can see a lot of patients still have not discharged. And you can see the type of visit, whether it's inpatient, outpatient, and at the very bottom, at the very far side, it's sort of hard to see there, you can see the unit. And so you can see if the patient's in intensive care or not. And so this is what the state uses. And so this is being populated real time. And the state then can be able to use this to do contact tracing. And of course, our state's using it to also confirm the data that they're receiving from the hospitals. We'll be adding additional information and drill down capability into this. So you can actually click on a patient's name and you'll be able to drill down into the health information exchange and pull back all of the patient's longitudinal record. Next slide, please. So in terms of lasting changes, I mean, these are the things that we really think about, and we're always trying to look into the future. So the COVID registry will be something that we provide for all of the markets that we work in for free forever, as long as we're continuing to work in the market. And so we'll make that available in 2021 for New Jersey, and it'll be something that the state can have as a resource to use. We also provide COVID alerting to all of the participants that we have in New Jersey. Alerting is one of the products that just comes along as a part of our health information exchange. And so once you participate with us, you receive alerting on inpatient and ED, but you also receive alerting on patients that have COVID. We also have added COVID information to all of our analytics. And because our analytics are proprietary to Kansa, if you guys there in New Jersey realize that there's something that you need, we can for you. We've actually done that for several physician groups in New Jersey that have asked for specific changes to the analytics product that we provide. And lastly, for all of you who are wondering whether health information exchange might really help you or not in managing COVID, One Health makes health information exchange at no cost now as a part of the emergency pandemic response. And so it's been available at no cost since May. And we extended the no cost availability until the first of the year. And it looks like, unfortunately, we're going to have to extend it further, at least here in the Midwest. And as we move out to the West Coast for all of our markets out there, things are not getting better. Things are getting worse here. And so we'll probably be extending the availability of the platform at no cost for providers beyond the first of the year. So with that, I will pause and look forward to taking any questions you might have at the end.
Well, great, thank you. I know there will be questions. I mean, just listening to your part of it as we transition to Jennifer, our next speaker. I mean, a year ago, we weren't really talking, HIEs were out there, weren't talking about them as much. Contact tracing and thinking about using an HIE for that wasn't in our vocabulary at that time. So it's amazing what this pandemic has done to force us to think about the changes and the responses that your organization and others are doing. And I think this is such a relevant topic for today's conference. So with that, let's keep it moving along to a longtime colleague, Jennifer D'Angelo, in addition to being a board member, is now on the New Jersey Innovation Institute for their healthcare division. So Jennifer, why don't you kick off and tell us a little bit about the NJHIN?
Good morning, everyone. What a great panel. Really excited to be participating, with my colleagues and really looking at interoperability across the state and how innovative we've become with taking data and being able to manage that with connectivity to other facilities, providers, HAEs, regional health hubs. So pleasure to be on with you this morning. So just a little bit of a backdrop about, before I go into NJHIN, just about NJII in general. So New Jersey Innovation Institute was formerly NJ High Tech and NJIT Corporation, founded in 2014, helping to turn innovative ideas into workable solutions. And we have 6 divisions: biopharma, data and advanced technology, defense, homeland security, entrepreneurship, and healthcare delivery and human capital. So, we've been operating in the state for quite some time. And I know sometimes people say, what really is New Jersey Innovation Institute? So I encourage you to go check us out on the website. But to take a deeper dive about New Jersey Health Information Network. So we have the pleasure of working with the state, and NJHIN is the only network, information network, that enables electronic exchange of patient health information among trusted data sources across the entire state of New Jersey. We are the only network also that can connect directly to state health databases. And NJHIN is owned by the Department of Health and managed, developed by NJII. So that's a very unique relationship. And I just want to make sure that we point that out here. We are also responsible at NJII for building those relationships with our trusted data sharing organizations, which some you've heard from already, including healthcare providers, HIEs, regional health hubs, and their ability to connect seamlessly to NJHIN. So we're in a unique position where we kind of sit at this higher layer and have the ability to work with these various organizations on interoperability and really pulling things together for the state of New Jersey. So NJHIN launched 2017, and we had a very aggressive approach in our onboarding process. And currently today, we have all 71 hospitals in the state of New Jersey connected to NJHIN, and we have a variety of HIEs and regional health hubs. So really building a robust data information highway and connectivity pathway for the state of New Jersey. So, who does NJHIN really benefit? So I think that the most important thing to look at here is interoperability benefits our patients. Ultimately, that's our goal, is to best serve our patients, and how do we serve them well? So by plugging in and working with hospitals, clinicians, medical practices, long-term care providers, FQHCs, ACOs, substance use disorder providers, regional health hubs, HIEs, the list goes on and on. So really it benefits these, variety of organizations, health systems to ultimately deliver the best care for our patients and families, and making sure we connect the dots. We're all collecting so much data. How do we really share that data, have it meaningful, and have it follow the patient where they travel so that that data is immediately available to provide them, our providers, with the best information that they have to care for these patients. So right now we have our current state of NJHIN, and we've really been working quite a bit with COVID. I recently onboarded to NJII, so I'm here approximately 6 months. Had been previously a customer of NJII, so walking into making this transition during COVID has really been a game changer. We've been working very closely, obviously, with the state and supporting their statewide initiatives and integrations. So certainly statewide ADT alerting that HIN provides. Master Person Index, we're looking at over 9 million identities that are coming into our system. We're supporting the IAS registry and the CDRSS registries. We're also looking and launching CCDA exchanges. So we are actively have that project underway and looking to really make a difference there with CCD exchanges at the state level. Having our provider directory available, and our modular projects, which we're looking at consumer access, where you're able to have your information via API and have that downloaded to consumer app of choice. So working aggressively on that, an e-consent program for SUD providers, perinatal risk assessment, and working with MPulse and partnering with NJHA on the MPulse project, which not only benefits the acute care facilities, but then also an added value for long-term care facilities to begin that connectivity and bridging the gap between acute care and long-term care. I think that we've seen a lot in this past 6 to 9 months with COVID and long-term care facilities, and really the focus to integrate them into our systems and onboarding them to our various registries so that we can continue to keep the data flowing from those levels of care back through to acute care providers and at the state level. So really quickly, I know that many of you have seen the New Jersey's COVID-19 dashboard, where you can get the latest statistics for COVID-19 cases by county, total cases for the state, confirmed deaths, and testing statistics. So this is a really helpful tool for folks in the state of New Jersey. You're also able to sign up for notifications and alerting. This is also assisting with contact tracing. And as you can see, there's a variety of different tabs and summaries up there, depending on the information that you want to drill down and look at. So your hospital census, discharge, long-term care, contact tracing, et cetera. So I encourage everyone to check that out and actually sign up to be a part of the alert notification system that the state is now providing for that. So COVID-19 impact, we could probably talk for hours and hours, each of us, on the COVID-19 impact, but again, at a very high level. Our role here at NJII was to immediately help the state initiative for enhanced capacity integrations in their infrastructure for CDRSS. So integrating CommCare with CDRSS to NJHIN with a bidirectional interface, which was completed, I feel, in record time, in 8 weeks. It feels like a lifetime that it took for this work to get started and planned out, but an amazing effort by various stakeholders that we've been working with at the state level to have those connectivity. And I believe New Jersey is still one of maybe 1 or 2, or the only state that's really doing a bidirectional statewide interface with CommCare CDRSS to a health information network. So the state onboarded over 2,000 contact tracers. And again, as we're managing the pandemic and the data and the collection, adding systems that we never thought we would need to add, and having that done in such a short time frame it has really been tremendous to see what we're able to do working together as a team and leveraging systems and technology that's available to us to be able to partner and help support these critical initiatives. Incomplete demographics and address information from partners has been a challenge, so we've been aggressively working on completing that information. So, information that we gain on registration is so critical to the flow of information, matching, having the right records, follow the right patient. So, having that information readily available and working, especially with all the pop-up labs and testing sites throughout the state, everyone was kind of implementing registration processes in a variety of different ways. So really coming up with some strategies to collect the right information up front so that that information accurately follows that patient and we're able to contact that patient for notifications, which is, has been a great challenge in some areas, and we've made great strides in trying to get more accurate information up front. And then just looking at the significant increase in the volume for ELR lab results. So those numbers obviously have skyrocketed and will continue to be on the rise. As my colleagues have mentioned, the numbers are increasing. And so, I think we're heading into the fall season now with COVID, possibly a second wave, and then we have flu season. So I think it's all that in combination now where the systems that we've been building and the integrations are really going to come into play and be critical now in the upcoming months to be able to track and trend and also isolate hotspots and keep people as safe as we're able to keep them. So it will be very interesting. So this is, I'm not always a big fan of putting up graphs and charts, but I just want to give a little bit of a snapshot of the trending of where we were back earlier this year to where we're trending now for the ELR weekly lab results that are being processed. So the numbers continue to increase and fluctuate, but just to give you a little snapshot of the trending. So processing all of that information and resulting and making sure that that information gets to the appropriate avenues and channels is critical at this point in time. So COVID-19 future opportunities, I think the opportunities could be endless. I think that, as all of myself and our colleagues on the line, looking at, what did we quickly need to implement to meet the demands of this pandemic, and what solutions will be sustainable for the future, and what will continue to be tweaked and best practices moving forward. Certainly collaboration with our HIEs, regional health hubs, and facilities throughout the state, and increasing data that we collect from them is ever more critical now than it was before. And, there's a silver lining in every situation. So I think that the advances that we've made in healthcare with technology, interoperability, data flow has just been so tremendous this year. And some of the initiatives that we probably would have projected out would have taken us years to complete. And now we've completed those initiatives in a very short amount of time. So healthcare is able to make change happen a lot faster than we might think that we were able to before. And certainly looking at telehealth is another critical component where, that technology and ability has just been so quickly integrated into our daily practices. So it's nice to see that we're able to utilize that and leverage that and have a sustainable model moving forward. So future opportunities for us here at NJDV, we're obviously incredibly busy, as is everyone else, in looking at statewide initiatives and working with our colleagues to onboard new use cases for data flow and connectivity. So looking at ELC and improving that surveillance and reporting of electronic health data to NJHIN, back to New Jersey Department of Health, and to ultimately CDC. So electronic case reporting directly to state registries is a significant focus of ours now. Transitions of care and use case data enhancements, we're looking to expand that data set and include a lot more information to be able to move that through. Enhanced data integrations. So integrations are key here. And, with integrations, there are pluses and minuses and challenges that need to be ironed out. So we all know how integrations need to plug in seamlessly. So having those in place is critical for us. And that's really one of our biggest focuses now. And secondly, interoperability for long-term care facilities, as we've mentioned numerous times during this webinar, assisting long-term care facilities with EMR selection for those that are not currently utilizing an EMR, connecting facilities to NJHIN, whether it be through direct connection to NJHIN or our trusted data sharing organizations, which some of you are on the line, ADT notifications, and CCD integrations to NJHIN. So as Laura had mentioned earlier, the ADT notification, so for the folks that are connected to NJHIN for the state and receiving our statewide ADT notifications, that is, you can check the box on the compliance for the ADT notification rules. So we can certainly provide more information around that. But certainly just so many opportunities, and looking forward to continuing our work with our partners and expanding services, not only with our colleagues on the line, but supporting the state with the many numerous projects that are happening simultaneously to continue to collect the right information that we need for COVID to protect the state of New Jersey and protect our patients and families across the state, and leveraging that information.
Excellent. Jennifer, great update, great information, and what you talked about there as far as, just how this four-star acceleration of change fits right into the theme of the conference here, with the game changers, and just hearing what these are at, and also hearing yourself, Christine, Laura, speak about the long-term care facilities and thinking back to how hard they got hit earlier on, how these types of things could possibly help in the future is really key. So continuing on and batting cleanup for us, we're moving a little north since New Jersey borders our friends in New York, and welcome Tom Moore from Health IX, which is up in the New York area. So Tom, let me turn it over to you to give us an update what's happening there.
Thank you, Jim. And I thank you to New Jersey HIMSS for having open borders and inviting me in to join you today. We are very much linked together. Our MPI, our Master Patient Index, shows that we have 2 million of our patients live in New Jersey. And a lot of the staff at HealthX work in New Jersey. So we are very much joined. And as Laura said, we are in the process of doing some integration with the One Health, and look forward to more and more data sharing across the river. If you want to go to the next slide. HealthX has been around since 2008, so we're pretty old in the HIE business, but over the last 24 months, we've had records on over 20 million patients. New York is a hub for many things, including healthcare. So we have a lot of patients in New York, but also coming into New York from the surrounding area. Next slide. We have tried to bring as many of our providers in the area as possible. We've got almost all of the hospitals, a large number of nursing homes, FQHCs, and a tremendous number of ambulatory practices. We're based in New York City, but have facilities up into Westchester and out into Long Island as well. Next slide. Our primary focus, as most of the HIEs, is on supporting clinical care with a portal and providing clinical records. We've also started to do more work to support population health initiatives. We work very closely with public health, and I'm going to talk more about that in a minute because that was a big part of the COVID-19 response. We have an active research committee with large academic medical centers that participate in HealthX and like to use our data for their studies. And we're just starting to branch into working with patient records. We have a couple of vendors we're working with right now who will be taking HealthX data and making it available to patients directly. Next slide. And just keep going. So here's a snapshot of what HealthX did with in response to the COVID outbreak. As you know, we were kind of ground zero for a while in the United States, and it was a pretty intense time for us. One of the things that we did immediately is we have an active alerting service for acute and subacute encounters, active with about 728 of our providers. So since we already had that plumbing, so to speak, there to push those alerts out, we created a new alert that was triggered by a COVID-19 test. And then any of those 728 participants who were already getting alerts, they just started automatically getting alerts that their patients were being tested and when those results were received. We didn't ask them, we just told them. We were able to make a waiver in our policy, a privacy policy to support that. And that was one of the first things we did. The other areas, both the New York City and New York State Departments of Health wanted badly to get data from our HIE. So we set up services with both of them where we were pushing data. Initially, it was daily files that were being extracted from the HIE and then placed on a shared server for the Departments of Health to access. We then moved to a more automated real-time system where CCDs, patient records, were pushed for anybody who was positive for COVID-19 to the state. And then anytime that record was updated as the patient's health situation evolved, we would push those records up as well. So you can see there were a large volume of data sent to the Departments of Health. We also set up our portal so that it could be used remotely. In New York State, consent is required for anybody to access patient records. So we made that consent process a telehealth process and enabled more access. And as you can see, there was quite a lot of access to the portal, especially at the beginning of the outbreak. And then finally, well, just two other things. One is there were a couple of field hospitals, as you might have heard, with the Javits Center and the Navy ship, and we provided access to the VA and to Northwell Health, which took over the Javits Center, to allow them to access HealthX records from those locations. And then in New York City, we have something called the Emergency Patient Search Function, and this is something that came out of 9/11 because at times of a mass casualty event, people are obviously looking for their loved ones and making sure that they're okay. And when they can't find them and they can't reach them, they start calling the hospital emergency rooms. So we set up this service to provide a central place of contact that the loved ones could call to say, I can't find my grandmother or my husband or whatever. And the 311 service is through the police department is able to access HealthX and find out if this loved one is at one of our hospitals. And this was used for 62 missing persons. Unfortunately, 38 of those had expired. But that takes a lot of the burden off of the emergency rooms to let them know. Last thing I'll say about this is the thing that was really remarkable about all of these things was how quickly they happened. In New York State, and I'm sure this is true in New Jersey to some extent, the privacy rules that surround access to health information are very strict and complex, and usually takes us a long time to approve use cases and then implement them. These things happened in about a week. A lot of the things that we were able to do that were a slight departure from policy were agreed over the telephone. And then the developers went right to work and put these things out quickly. So it's just very interesting to see what can be done when everybody comes together and has a great sense of urgency, as we did here. Next slide. Thanks. So how has this changed the way we do things? Well, you know, we had been providing alerts. A large number of our providers had, you know, considered them a vital part of their operations, but after COVID-19, it raised the awareness and the sense of urgency and necessity much higher, because of this is the only way that they could find out about what was going on with their patients during this time. The other thing is our relationship with the departments of health has grown much tighter, and I think that is here to stay. I think we're going to be working much more as partners, much more closely with them as partners than we ever had before. I think that will continue. We had been working on a project with the Department of Health to detect antimicrobial resistant infections such as MRSA, and that has been expanded, as well as our predictive analytics to account for things related to COVID. So I think that will also be a lasting change. Next slide. The other area that we've seen a change in is the work that we do with partners. So we have an analytics firm that we work with that's now detecting early signs of Kawasaki disease, which in children, which, as you may know, has been associated with COVID-19. One of our participants out in Long Island, Northwell Health, has developed an application for their catchment area to detect outbreaks early, you know, hotspots of where the disease was happening. And they've now expanded that to work with the HealthX data so that we can cover the whole city. And ultimately, they hope for it to be a statewide application. And as we get information about tests and immunity and so forth, we want to put that information into the hands of patients. We have a vendor who's working with us to access HealthX data to give a patient their COVID status so that they can use that for safe entry into work, school, and other public places. And then finally, we work with a lot of EHR vendors. That's kind of our mainstay of our business, to bring regular clinical data in. But we've been expanding that to work with vendors doing care management, population health, remote patient monitoring. We have Chinoa right here in New Jersey, who's developing a remote patient monitoring application. We're working with them to use HealthX for that. And so all of these patients, all of these vendors are adapting very quickly to requirements that are new challenges that are brought up by COVID-19. Next. And then finally, what we're doing here, what's happening for the future as a result of this. One of the things, the kind of lessons learned, is that we have to be prepared to move quickly to launch new alerts as new things happen. And that was certainly what happened during COVID. It's critical that our system monitoring is really up to snuff. We do a lot of it now. I think we're going to be doing a lot more because of the intensity of the need for the data and for it to be available at all times. And then finally, you know, data quality is always challenging when you mix a lot of different data from different sources together. The work we did with the departments of health really highlighted where some of the anomalies were by the diversity of the data, and allowed us to quickly make some changes. That, I think, will move us towards more continuous improvement of the data to support these types of use cases. So that's it for me. Thank you, and I look forward to the question and answers.
Excellent. Thanks, Tom. And you and Jen hit upon something that will hopefully look at as we roll into the Q&A, and I pull Kennedy back into the discussion, help facilitate that whole piece about data quality. Talk about the MPI with Jennifer and talk about your data quality, something that, if time permits, and as we get the questions coming in, we'd love to explore. So at this point, while I pull Kenny in to help facilitate us through the Q&A, I'll remind everyone that if you do have questions that you'd like us to do, we have about another 10 minutes or so that we'll try to go through the Q&A with the panel here. Please submit them through the Q&A feature on the Zoom. And with that, Kennedy, if you're out there, I'll let you guys kicked off with the Q&A.
Okay, great. I just want to offer a profound thanks to all of our panelists today, to Christine, Laura, Jennifer, and Tom. One of the things that I'd like to bring everyone's attention to, for many of you who have been in the health IT space for a long time, over a decade, this all had its roots in the Meaningful Use program that helped build the digital infrastructure that we can now rely on. And every one of our participants today have roots in the original HITECH Act and have built some of the oldest and most progressive HIEs here in the country. So I'd like to formally declare, at least from a clinical standpoint, the HIE is back. And I had the privilege of talking with Dr. David Blumenthal, I guess you can say the father of meaningful use, at one of the National HIMSS conferences about public health, which is, if you recall, is a pillar of the Meaningful Use program. And I don't think there's good evidence to suggest HIEs ever went away, as clearly evidenced by our panelists today. But now it's such a huge and viable means of standing up public health. So thank you very much to all of our panelists. So we've got some robust questions today. Now we're going to go ahead and we're going to start with our first panelist. What are the biggest challenges you have to provide quality data or data quality? I guess we could also talk about data integrity as well for our panelists. I know Jennifer and Tom touched upon that. Would someone like to take a stab at that? Laura or Christine?
Thanks, Dr. Gonti. I'll take a stab at it. I mean, we look at this all across the country, and we do think that the data quality is improving. But, in part, we are dependent upon the quality of data that's entered at the participant level, so our hospitals and our doctors, and then the quality of data that can actually be transported across the interfaces from our EMR vendors. And so those are things that we really are beginning to focus on. As a matter of fact, we've hired a couple of new staff positions called HIE workflow specialists. And these are clinical staff, usually nurses, that work with our hospitals and our practices and skilled nursing facilities and others to help make sure that data is entered completely and correctly. So we're starting to move into a whole new area, I think, with health information exchanges, where in the past we've just focused on getting the connections done. And now we're focused on making sure that the data that's coming across is complete and correct. And we're starting to see new positions. I've got a whole quality team now that, 5 years ago I didn't have, that just really focuses on the quality of the data. So it's an emerging field for people who are interested in really looking at data quality from its inception, when the doctor enters it, to when it actually comes into the data lake and is available for public health or other purposes.
Any other opinions or thoughts as to what's going on in your respective areas to our panelists?
Oh, sorry, go ahead, Jennifer.
I could just add a little bit of for us, at the state level, and looking at our conformance reports and looking at the data that's coming in and looking at those numbers and working with all of our TDSOs to make sure that we increase that conformance percentage to the highest level that it's able to be. So, continually being on top of that, we provide a lot of information to the TDSOs and helping them achieve higher rates of conformance to try to keep the, obviously looking for quality data is critical to this process. So, that's at the forefront and something that we, focus a lot of our time and effort. But to Laura's point, that is an emerging group of skill set and folks to really have dedicated resources looking at that on a very regular basis. The more we expand data collection, the more we need to expand the quality reviews and checks of that.
Great. And Christine, would you like to conclude with your answer?
Thank you. Yeah, I don't have much more to add. We have taken a very similar approach, like Jennifer said, working with NJDV on conformance reports. So we have a sense of the quality of the ADT data we're sharing on behalf of our regional hospitals to the HIN and what we're receiving back. And as Laura mentioned, we also have partners that we work directly with, sort of in that workflow specialist kind of skill set of thinking about how are we collecting data and what are some barriers to that, and what are creative ways we can go about improving the quality of data while also documenting what some of those systematic barriers could be. So one example I've thought of recently was some of our efforts around looking at data that's collected for patients who may be eligible for lung cancer screening. And there are discrete fields in an EMR where often you can collect information like PAC years and smoking history, but sometimes those aren't completely filled out and are instead filled out in some sort of narrative form as part of the summary of a patient's visit. And so we have worked with practices to sort of identify when, certain fields in the EMR may not be used, but we may be getting the data otherwise, and thinking about, how we can make those improvements and make it easier for physicians to document data.
Fantastic. Thank you for that wonderful answer. Thank you for handling that question. I'm going to pop to the end. An anonymous attendee said, do HIEs talk to each other? Is there still a siloing data given competitive HIEs? I'm going to go ahead and answer that question because I think all of us addressed that issue in the substance of the talk. Jennifer helps direct and manage the New Jersey HIN with NJDV, and they oversee healthcare data exchange throughout the state of New Jersey, for which One Health is a participant, the Camden Coalition is a participant, and then you've already heard about work being coordinated, connection being coordinated between One Health and Health IX. So the answer to that question is an emphatic yes, and I think we're going to be looking towards Jennifer's leadership as well as in the state to continue to connect all the entities that they hope to connect at the NJ HIN. So we're going to get that question out of the way. Transitioning quickly, Christine, this question is aimed for you. If you can share any insight into the clinical adoption rate of your thin client EHR prior to and after COVID.
Sure. So prior to COVID, we really had only used the thin EMR with our internal team here at the Camden Coalition. We have a team of nurses, social workers, and community health workers that were using the HIE to document our care management activities with patients and sharing that with other providers. COVID was actually really the starting point of us offering that services more broadly to our external partners, mostly for the reason of knowing that there's a lot of great services that EMRs locally are offering and opportunities for providers to document and not wanting to ask them to, of course, double document. But when we got to this point of sort of having a pilot project that needed to get stood up very quickly, which was the quarantine hotel in Camden County for patients who were not able to safely self-isolate, that was a good opportunity for the HIE to quickly turn this form into action and be able to offer that to our partners. And since then, we are continuing to work with the Camden County Health Department to offer more documentation services. So we don't have, the good numbers right now to say what our adoption rate is, but I think the biggest piece of we've noticed that has contributed to the success of wanting another platform to document in and committing to, going through all that form building is really making sure that we're co-designing what the workflow should be with the partner and talking with them about at which points do they interact with the patient and what questions need to be available and easily accessible to make sure that documentation happens in a fluid way. So, hoping to report back at another NJ HIMSS presentation about how that program has been going and our success rate with that.
Great, thank you. I know that both One Health and Health IX also have thin EHR clients, and this is a great topic on adoption, especially ad hoc adoption by different agencies. But in the interest of time, I want to move on to a couple questions. One more is, how can HIE data be used for patient identification when COVID-19 therapeutics and vaccines are available? How will HIE organizations and providers support informed consent for patients in any outreach models that are developed? I'll leave that open, but then look for an initial participant, but then I know who I'd like to ask on this question. Okay, I'm going to aim this, try to have Jennifer look at this because, being involved with the state, with the Department of Health, and there's no doubt been discussion about, pending vaccines and how to collect that data. Where are we at the state level and the NJ HIN level on that, Jen?
So that is part of some of the initiatives that we're working on now for integrating to those exchanges, and certainly looking at our master person index for that unique identifier to connect the dots and deduplicate across the state and making sure we have the right patient with matching up with the right result and having those results come back into and flow out of the HIN through our alerting system. So we are in active discussions at the state level to integrate those results and have those get pushed out via our ADT alerting.
Great. We've got a lot of wonderful questions coming through, and unfortunately, in the interest of time and just such a meaty topic, I'd like to conclude with one more question in order that they were received. And this is another question for Jennifer. What, if any, IT security initiatives or plans does NJDI have going forward outside of providing secure integration and access? Things like patient education, awareness, developing security guidelines, recommendations for member organizations, etc. Possibly providing member discounts for IT security related products, licensing, and services integration that promote or support overall cybersecurity. Statewide alerting of cybersecurity events / incidents. A cybersecurity question, very, very apropos, very important. Jen, we're going to conclude on that question. So Jen, please take it away.
Sure. I don't have a lot to report on that question, but it is a very, very significant question as we continue to integrate systems and increase the data and services that are out there. Cybersecurity is the uptick there is trending along with as quickly as we're moving to new systems and integrations. So, for their NJDI, currently we don't have any plans for security awareness training initiatives, but that certainly is something that we could look to work with the state in developing. I would recommend everyone go on to the state cybersecurity website, sign up for those alerts for events and incidents, but certainly great question and something to definitely take into consideration as we continue to move forward with these various platforms integrations. We all need to make sure that our systems are secure. And that is an initiative that we all need to collaborate on and be a part of.
All right. In the interest of time, anyone have any last minute thoughts? I don't want to cut anybody off or leave great ideas on the table. All right. In the interest of time and moving on to our next program, I want to really thank everybody for working with myself and Jim on putting this wonderful program together. Such a needed program. And whatnot. And we have a lot of other questions that we weren't able to answer on HIEs and fundamental functions of HIEs. So seeing that, seeing the robust participation today, the attendance today, we will at New Jersey HIMSS make it a point to see if we can continue a dialogue on as well as presentations on the health information exchange and its rise through the need for public health. So I would like to thank our panelists today, Christine, Laura, Jennifer, and Tom. I'd like to thank Jim, who helped put this together as a labor of love. I'd like to also thank Diane and Melissa from Damaris for helping us put this on, as well as the board of New Jersey HIMSS and our members for attendance, as well as our partners over at DV HIMSS, where all of these wonderful events are not possible without superior regional collaboration. So we look forward to bringing you more programs in the future, and thank you very much. And I leave you today with having to go and do my day job. So I'm going to go protect myself, do some live visits, and I bid you all adieu from here in my primary care office on behalf of the board of New Jersey HIMSS. Have a great day, folks, and thank you for attending.
Thank you.
Thanks, Kenny. And before we all wrap up, let me just, I've been tasked with the end of session housekeeping. So in addition to thanking all the participants on our panel, as well as everyone in the audience for joining us today, just thank you for a great session and a great start to day 2. A couple quick reminders. One is to make sure that you visit our virtual exhibit hall that Elliot sent a link to in chat earlier. We rejoin again at noon for our keynote speaker, Russ Branzel. And then I've been provided the winner of this session. So the $200 session winner today is Rose Williams from Christiana Care. So congratulations, Rose. Folks from the panel, folks from the conference setup here will be reaching out to you with that information. And just want to, again, thank everyone for joining us this morning. And I'll just turn it back to our conference facilitators, Diane or Melissa. Any other closing things that we need to do before we wrap?
No, I think we're good.
Excellent. Thank you, everyone, and look forward to enjoy the rest of the conference. Thank you.
Thank you.
Thank you.